All right, this is Mrs. Ignacio and a bunch of motivated nurses. Okay, and so I am asking questions of the group because we have a mixed group of ADN and PN students on what's important for them for foundations. So I have a question from the group that's saying, a young mother of 3 children complains of increased anxiety during her annual physical exam. What information should the nurse obtain first? So I really want to ask a lot of different questions, and I think she's going to list the answer choices. But when a patient has increased anxiety and she has children, I'm automatically thinking safety of herself and safety of the children. Okay, so that's going to be one of the first things that comes to mind. And I'm going to need a little bit more information about it. But safety of herself, safety of the children is one of the first things that comes to my mind. Okay, let me see what you have put in the chat. So you have asepsis. Asepsis really has nothing to do with it.
Sepsis and cholesterol was just one of the categories that I just wanted to speak about, but
Oh, okay.
yes, but the answer is listed below.
The answer is nutritional history. Okay, what were the what was the other choices? Because that
I don't remember the other choices. I can. Oh wait, I still have it up. Hold on, just a second. I can give you the other choices. Hold on, just a second.
okay.
Um,
And the reason why I'm trying to determine is I know that sometimes if our patients have anxiety, they may not, that's true, they may be malnutrition, but I'm thinking safety is first. But when you have these questions, you have to choose from the best possible choice that's presented. So it sounds like there was nothing with safety. That's what I'm maybe understanding.
I'm coming. I gotta scroll. It was like 79 questions.
Okay, no, that's okay. That's totally
Okay.
fine. And so I see you have asepsis and cholesterol. I understand now as topics to discuss. Okay, I've got it.
Okay, so the answer choices were sexual activity patterns, nutritional history, financial stressors, and leisure activities.
Oh, leisure activities.
I'm sorry, leisure activities.
Mm-hmm. I'm really, so say those again for me. Financial.
It was sexual activity patterns, leisure activities, or financial stressors. And the reason why they put nutritional history was the caffeine, sugar, and alcohol can lead to increased levels of anxiety, such as nutritional history. But I was just confused with this question.
Okay, so let me just write this down so I make sure I touch on each of these. So sexual activity. So the question that they're asking, they're trying to figure out why she has anxiety or he has anxiety. That's what it sounds like the question is asking. So I like what Makaya also said is how long and when did the anxiety start? So when we think about what can cause a patient to have anxiety, it could be stress, and we know that stress comes from different places. And so the financial could be one that I probably wouldn't have thrown away. And then sexual activity, that may or may not be related to the anxiety. And I have financial, sexual, and then nutrition. And what was the fourth one again?
Financial stressors.
Yeah, financial stress or sexual activity, nutrition, and what was the other one?
Leisure activities. No, it
Oh,
was sexual activity pattern, nutritional history, leisure activities, and financial stressors.
hmm. Okay, I don't know if I love this question. Um, Let me just look at the way that you put the question. A young mother of three children complains of increased anxiety during her annual physical exam. What information should the nurse obtain first? Financial stressors, sexual pattern, sexual activity pattern, nutrition, and leisure. You know, I'm kind of torn because I don't think that I would really ask nutrition. I would probably ask about leisure first, to be honest with you. Um, Read the rationale again, please.
It just kicked me out. I should have took a picture of it. It
Oh,
just,
sorry, because
yeah, it just kicked me out.
I don't know if I love that
Yeah,
question.
that was one of the questions that I was like stuck on yesterday.
Okay. So great question. So if there are HESI questions like this, can they be challenged and can they be thrown out? No, no, because it's not made by us. This is made by Evolve. It's made by Evolve. So one of the ways to kind of combat this, kind of scenario is the more questions you do and the more rationales. That's why I was kind of interested to see what they said the rationale would be. So that's why, like, even me, I still do questions every day because I learn something new every day. And sometimes I get questions wrong, and I'm like, why did I get that wrong? And I'm like, oh, sometimes it makes sense to me, and sometimes I'm like, I don't know if I agree with that. So, and this question is one, I don't know if I love this question based on what you're telling me, but I think what you were saying was the nutrition foods that can cause anxiety or increase heart rate could be, like foods high in caffeine. So I get that part of it. But I don't know. I don't have a final answer for you, Brittany. I'm sorry about that one. I don't know if I love that question or not. I would have
Okay. Yeah,
to.
some of the questions be tricky like that on the HESI, and I just be, I'm like, oh my goodness.
I know. Well, I mean, I'm sorry I don't have a final answer on that. I'm gonna have to phone a friend, and I'm writing it down. Trust me, I'm writing everything down because I try to research afterwards to say, okay, because there's somebody that's smarter than me that knows about this stuff. Okay, so that's the beauty of having a lot of friends that are nurses. Okay, so I also see that you have some questions about asepsis, okay, about asepsis. So when we talk about asepsis itself, we are thinking about what is going to be the safest for the patient because we're getting ready to do an invasive procedure. It could be a surgical procedure, like in surgical asepsis, or it could be insertion of a Foley catheter, right? Insertion of a Foley catheter. Okay, and give me 1 second, please. Hold on. Okay, all right. So sorry about that. Okay, so sepsis, asepsis. So whenever a patient has a procedure done that is invasive and that we run the risk of introducing bacteria or any contaminants, any pathogens, that's when we have to practice the aseptic technique. So some principles of sterility that you should know that could be on test questions for sure is that when we set up our sterile field, we usually use maybe a drape, or we have, if it's like for a Foley catheter and we have the kit, 1 inch around that border is not sterile. Everything inside that border is going to be considered sterile. So with the principles of sterility, we will never reach across our sterile field. We will never place our hands below our waist. We will never turn our back on our sterile field. We will not cough, laugh, or sneeze over our sterile field. If something becomes contaminated in our sterile field, we have to start all over again. So if, for example, we're inserting a Foley catheter, that is a sterile technique. If we're doing a NG tube insertion, that is a clean technique, so that's not sterile. If we're doing wound care, I've seen both ways where we can have a clean technique or a sterile technique, but I personally prefer the sterile technique because you don't want to introduce any pathogens into the wound. Okay. And if we're going to the OR, the operating room, that is sterile, and we have to set up our sterile field. We have various people that are in the OR. We have the circulating nurse. We have the surgical technician. We have the nurse that's responsible to help scrub in, and that could be the scrub nurse. And we know that before the procedure happens, right, we have the room, it's set up and it's really cold because the temperature is kept down to reduce the reproduction of any pathogens that may be present. We do the timeout procedure. And this is a little bit of like your perioperative, kind of thing. And so let me put timeout procedure. And during this timeout procedure, we make sure that this is the right patient and this is a safety. Everybody stops what they're doing and they say, this is Mrs. Smith. This Mrs. Smith is here to have her right leg amputated. This is the right leg. And so that's a procedure to keep the patient safe. Now, when we think about sterility, in the surgical field, only the part that the patient is operating on is going to be available. Everything else is kind of be like behind a blue sheet or a curtain. Everything else will be wrapped. And we think about we'll be wearing, our bouffants to keep hair from falling into the sterile field. So that's why no false eyelashes are allowed, those kinds of things, false nails, because it's just, we don't want anything to fall into the sterile field or to fall into the patient. Okay, we'll have goggles on, we'll have face masks on. If someone has facial hair or a beard, they will have a protecting cover so none of the hairs can fall into the patient as well or contaminate the sterile field. We'll even have our booties on, right, to protect our shoes because we know that our shoes are dirty. So those are all things. And of course, we're going to scrub in from our fingertips to our elbows, removing all jewelry, watches. So that's, we scrub in for at least 3 minutes vigorously. So all of those go with your principles of asepsis. Okay, so I'm going to pause for a second and and see if that answers your questions about asepsis, Brittany.
Yes.
Yes. Okay. So Micaiah said that there's two. Okay, great. All right. Excellent. Okay. I'm going to come back to your cholesterol question because Micaiah gave us something. Let me see if I can open it. Oh, something is really weird on my computer. I can't open this picture for some reason. So can you read what it says? I can't see it.
Yes, it says a male client with venous incontinence stands up and his blood pressure subcutaneously.
Oh, wait.
Can you see it?
Okay, yes, I think you can still read it though. That is still helpful, please. Okay.
A male client with venous incontinence stands up and his blood pressure subsequently drops. Which findings should the nurse identify as a compass? What's this word?
A compensatory response.
A response. And they have listed for the answer choices bradycardia, increase in pulse rate, peripheral vasodilation, and increase in cardiac output.
Okay, so let's paint a picture of what's going on here. And this might be a good kind of thing to do with all of your questions. Paint a picture of the patient as the question is revealed to you. So we have a male client, and it doesn't really matter if it's male or female. That's just kind of a distractor. So we have this patient. They have venous incompetence. So I know that they have issues with their veins, okay? And so he stands up and his blood pressure drops. So that tells me that, because I know a little bit about the blood pressure when the patient changes his or her position, if they go from lying to sitting, from sitting to standing, and their blood pressure drops, that is orthostatic hypotension, right? That is orthostatic hypotension. Now, this patient, when their blood pressure drops, their heart rate is going to increase. And the heart usually does that unless the patient is in shock or something else is going on. But as the blood pressure drops, you could expect that the heart rate is going to increase to try to compensate for that. Okay, so we know that it's because of that, it's not bradycardia, right? And because we know that this question is basically asking you, do you know what orthostatic hypotension is? Okay, and let me put that in the chat so everybody knows. And so if you're here and you're like, I don't know what orthostatic hypotension is, please ask something. But if you're also listening to this video later on, and I'm going to try to explain, if you still have questions, that's something to go back and look at. So with orthostatic hypotension, again, what happens is the patient's blood pressure drops when they change position quickly, from lying to sitting, from sitting to standing. So this patient is a fall risk. And so what happens when the patient's blood pressure drops, the heart rate increases as the body's trying to compensate. So when we look at the choices, bradycardia, I know that it's not because of bradycardia. Now, if it said that the patient was performing the Valsalva maneuver, maybe they were straining to pass their stool, I could probably say maybe it is bradycardia. But for this case, it is orthostatic hypotension, okay? And so this question is also asking you, what is the compensatory response? So how does the body compensate to make up for this venous issue with his blood pressure dropping? So I think you probably maybe knew that, but maybe didn't fully understand the question. So let me pause for a second and ask you, Micaiah, is this, do you understand the question or?
Yes, I understand now. I think when I first went through it, I was thinking orthostatic hypertension. That's why I chose bradycardia instead of at the end when it said it, to compensate. That was the key point.
Okay, yes. Okay, so that's a really good point. And I'm really glad that you actually brought this out, because one of the things in the test taking strategies, because I feel like, you know, students know a lot, but the way the question's worded, it may be unfamiliar, and that might be the confusing part. So always ask yourself the question, what is this question asking me? Paint a picture of what the patient looks like. Walk into the room and imagine yourself, hi, my name is Micaiah, I'm your nurse, and you see a male patient and you know that this patient has venous incompetence, and he starts to stand up and whoa, you get the blood pressure drop. Like, kind of paint that picture in your mind, and that might help. Okay, so now let's just talk about the other choices as to why they're not correct. So peripheral vasodilation. Now, if this patient has venous incompetence, he's probably going to have vasoconstriction. Okay, he's going to have the opposite. And this is also going to be a decrease in cardiac output. So it's going to be the opposite. Okay, going to be the opposite. Let me see what the rationale says. When postural hypertension occurs, the body attempts to restore arterial pressure by stimulating the baroreceptors to increase the heart rate. Okay, peripheral vasoconstriction, not dilation, the veins and arterioles. Okay, got it. The decrease in cardiac output, not an increase. Okay. All right, that's a really good question, and that is actually a very important concept to grasp because you're going to see it in med-surg, you're going to see it on the NCLEX. That's an important, so make sure you got it. All right, any questions about that one? Okay, all right. Let's go to the next one. A male client arrives at the outpatient surgery center for a scheduled needle aspiration of the knee. He tells the nurse that he has already given verbal consent for the procedure to the healthcare provider. Okay, what action should the nurse implement? Okay, so the male client, it doesn't matter if he's male or female, that's like a distractor. He's going for outpatient surgery. The procedure really doesn't matter because this patient is having a procedure that they have to give consent. They have to have informed consent. So the fact that he's given verbal consent is great, right? But we still need to make sure that we have it in writing, okay? So the question choice, the answers are witness the client's signature on the consent form, verify the client's consent with the healthcare provider, notify the healthcare provider that the client is ready for the procedure, document that the client has given consent for the needle aspiration. So this was a tricky one because this is basically saying, what do you understand your role as the nurse if a patient is having a procedure done? And we are not responsible for explaining the procedure. We are responsible for making sure that there's a signed consent form that is placed in the patient's record. Now, the way this scenario is being explained to us, the patient gets it. The doctor talked to them, everything is good, and they just have to sign the paperwork and we get it into their record. Okay. So we don't necessarily have to call the healthcare provider again. So it says written informed consent is required prior to any invasive procedure. The healthcare provider must explain the procedure to the client, but the nurse can witness the client's signature on the consent form. And that is true. Okay. B is not necessary since written consent must be obtained. It is not correct because written consent has not been obtained. Okay, and then must occur after written consent is obtained. Okay, so the bottom line is this question is asking, do we know that we have to make sure that we have a signed consent? The fact that he verbally said it is great, but we need to witness it and get it into the record. Okay, any questions about that one? Okay.
In a situation like that, and the client is so weak to sign. I know next sex the other time she said the nurse can be there when the client verbally tell the doctor that the procedure can be done. Or if there's a next of kin, he can sign the consent form on behalf of the patient, isn't it?
Yes, if that next of kin, so the patient must sign. Now, if the patient cannot sign, they're incapacitated, they're too weak, they're confused, whatever, they must have a next of kin who is designated the medical power of attorney to make those medical decisions. Okay, because if we don't have something signed, technically we can't do the procedure. Okay, we can't do the procedure. Now, if this is like an emergency, that might be, falling under different kind of guidelines, but this sounds like it's a routine procedure. The patient's coming in, but the patient must sign, or a family member, because it could be a patient that has dementia that may not understand, or a cognitive issue, but somebody must sign to say that they acknowledge what the procedure is, what the risks are, and all of that. So we have to have it into the medical record because that is a legal liability. Okay, does that help answer your question, Amanigo? I don't know if it does or not.
Yes, thank you.
You're welcome. Okay, and so remember that NCLEX is testing us. Are we going to be a safe nurse? And, safety is, hand washing. Safety is, putting the bed at the lowest level, those kinds of things. But also safety is preventing your institution from having a lawsuit. Okay. So that's safety as well. Okay. All right. Excellent. So now I'm going to answer the other question about cholesterol. So it was a general kind of question about cholesterol. So when we think about cholesterol, we're going to break it down. So we know that if a patient has high cholesterol, it could lead to heart disease like atherosclerosis. So cholesterol is really important to understand, the effects. Cholesterol is made most in our body at night. So that's why if a patient has high levels of cholesterol and they're taking their anti-lipidemic medication, they should take it at night. They should take it like simvastatin. They should take it without grapefruit juice, right? They're not allowed to have grapefruit juice. So let's talk about the actual cholesterol and what does the values mean. So we have our LDLs, which are our bad cholesterol, and that is the one that causes the blockage in the arteries. The HDL is the good cholesterol, so that's like your omega-3s. If you eat salmon, if you take fish oil supplements, olive oil, those kinds of things. And we always want our HDL levels to be higher. Total cholesterol is the combined amount of LDL and HDL. Now, triglycerides is another part of the cholesterol equation, and that's a type of fat found in your blood. Okay, some studies show that high level of triglycerides may increase risk of heart disease, especially in women. Okay, so let me give you the values. I don't know if I can, let me share my screen with this here and this value is coming it's coming from Medline, but as you're getting ready for NCLEX, I would definitely say if there's any discrepancy, and I'm going to look at this looks actually pretty good. If there's any discrepancies in the values, you could definitely use I recommend you use what's in your Saunders book. But so let's take a look at this. When we think about total cholesterol, we want it to be below 200, and that's a standard, 200 is what we're looking at. Okay. Anything between 200 and 239, that's borderline high. 240 and above is high. Okay. And again, as that number increases, that places your patient at risk for heart disease, heart attack, stroke, right? Atherosclerosis, all of these other negative things. We think about smoking, sedentary lifestyle, obesity, uh, diabetes, all these other comorbidities that go along with it that increases the risk of your patient to have not have a good outcome. Now, LDL is your bad cholesterol. We want it to be less than 100. Anything higher than that, it's getting increasingly, concerning for the patient and their health. HDL, we want that number to be the highest as possible. 60 and higher is really good. That's protective against heart disease. And then anything less, of course, is going to be a major risk for your patient. Okay, I'm going to stop sharing. So another thing that could be asked is, okay, who's at risk? Well, those that have high blood pressure are at risk. Those that have diabetes, type 2, those that smoke, those are obese, have a sedentary lifestyle. They have a diet that is high in fat. Those are all risk factors. Okay, so these cholesterol levels can be taken via blood work. Okay, so the blood can be drawn from your patient. I would teach my patient, if it's, keeping in the vein of cholesterol, teach my patient about healthy eating, diet, exercise, being active, eating foods that are rich in omega-3s, leafy greens, fresh fruits, drinking plenty of water. Those are all great things to help the patient with their cholesterol levels. Okay, I'm going to go to Brittany because she had the original question about cholesterol, and I'm not sure if that has answered her question.
Yes, that helps.
Okay, perfect. All right, excellent. All right, so, and I just put that link in the chat. Okay, so since, okay, any other questions before I go on?
No.
Okay, awesome. So let's go now. I'm going to do some questions with you. Okay. All right, let's see. Okay, oh, let me make sure everybody knows how to get to these questions. They may not know. Okay, give me 1 second. I'm going to share my screen. Okay, give me 1 second. Um, hmm. Oh, it's not letting me see these questions. Oh man. Okay. Okay. Well, I'll go do it this way. All right. Um, okay, I'm going to do from the green book and also from the burgundy book, just because we do have LPNs here and ADNs here. So let me share this with you. And it's more so to look at the concepts and so to help you break down the questions as far as the materials go. Okay, let me see. Okay. And actually, before I do that, let me just go over some topics. So let me tell you the topics. I forgot. That's what I had this other tab open for. And see if you have any questions. Let me stop sharing for a second so I can see if you have any questions about these topics before we go over those questions. Okay, so for fundamentals, you can, it ranges from patient safety and quality, hygiene. So we think about, the chain of infection, the importance of hand washing, sterile technique, clean technique. We think about critical thinking and nursing practice, right? Being problem solvers. We think about ADPI, the nursing process, the assessment, the nursing diagnosis, planning, intervention, and implementation and evaluation. We always want to use Maslow's hierarchy as we're prioritizing. That's something that's covered in fundamentals. Also, we think about our skills, because your skills can also be questions, right? Making that occupied bed or the unoccupied bed, making sure that we're not shaking the sheets, we're doing everything on one side, asking the patient to roll over or getting assistance, making sure that the sheets are free from wrinkles, because we know friction and shear can increase the patient's risk for skin tears or skin damage and pressure ulcers. When we think about activity and exercise and immobility, think about how we prevent immobility as far as contractures. That's going to be our active range of motion and our passive range of motion. So active range of motion, the patient can do on their own, right? And so passive range of motion is that we must do for our patient, and it takes just 48 hours if a patient does not have their range of motion performed for those changes, those physiological changes start to take place that could change, and our patient can end up with contractures, right? So that passive range of motion is very important. Think about if you have an immobility question, I want you to think about body systems and what happens in our patients that are immobile. And this is good for LPNs and for ADNs. If my patient is immobile, I'm concerned about their skin. I'm concerned about pressure ulcers, staging the pressure ulcers from 1 to 4 to even to unstageable. Remember, stage 1 is going to be non-blanchable. If I press it, it's pink, it stays pink. Pressure ulcer, second stage, we're going to have a loss of that epidermis. And as we go to stage 3, now we're going down to the dermis. Stage 4, we're going past the dermis all the way past the subcutaneous layer to the bone. Unstageable, we're thinking that it's black, it has eschar. We don't know how long the patient had this, right? So again, this is a complication of immobility. Respiratory wise, we are concerned if the patient is immobile because they can have secretions that are pooling. They could be at risk for pneumonia, atelectasis. So how do we, as nurses, do something or implement something for a patient? Turn every 2 hours and reposition the patient. We can teach them to cough and deep breathe and to splint, right? So those are all things to think about. Use of the incentive spirometer every hour during the time that they're awake, right? So those are all important things when we think about caring of the immobile patient. So think about restraints. What can you all tell me about restraints?
I think it has to be, I can't think of it, never mind. Is it 2 fingers?
Yes, 2-finger breaths right between the
Yeah.
patient and the restraint. So that's very good.
And then the type of knot that you have to have up there.
So
I
it
can't think of
is,
the name of it.
it's a slip knot or a quick release knot. Very good. And so it's going to be tied on a part of the bed that does not move. And so,
Mhm.
yes, that's very good. So 2-finger breaths because we don't want it to be too loose. We don't want it to be too tight. Yes, Makaya, we do have to have a doctor's order. The doctor's order is good for 24 hours. And the patient, when we have this restraint, they're going to start what's least restrictive to most restrictive, right? So we will only use this restraint if the patient is exhibiting behaviors that requires a restraint, like they're pulling out their NG tube or their Foley catheter because they're confused. Once the patient is no longer exhibiting those behaviors, then we will contact the healthcare provider or our chain of command and get that restraint discontinued. Once that order is discontinued, then we can remove the restraint. So there are physical restraints or mechanical restraints and chemical restraints. And so we don't want to chemically restrain our patients. So I'm looking at Shatavia's comment. So no, we're not going to give, Ativan and say, okay, take a ride in my van. Here's some Benadryl or diphenhydramine and some Ativan, I'm going to put you to sleep, because that's actually a chemical restraint, and you can't do that to your patients, or you shouldn't do that to your patients. And we are going to try from least aggressive to most aggressive, okay? And I do have a restraint handout. Let me share that with you. But you're right, and it's good for 24 hours. We do need a doctor's order. And let me see what else I can tell you about restraints. You have to remove the restraints every 2 hours in order to check for neurovascular checks, okay? Neurovascular checks. So I just put into the chat a handout for restraints, okay? Because that's going to be a good thing to kind of review. Okay, and let me share my screen for those that are watching the video. Okay. And I like all of the inputs that you all are putting into the chat, so thank you for that. Okay, so this handout on restraints talks about the spectrum least aggressive to most aggressive. So of course, we're going to try to redirect the patient and then We can have the mitts, the posy vest, soft wrist restraints, 4-point restraints, chemical restraints. Okay, and that's what Shaitavia was saying in the chat. Try all other restraints before pills, because that's going to be a chemical restraint, and that is a very aggressive form of restraint. And then, of course, we have to look out for the complications that could occur if we perform this chemical restraint of our patient. So nonviolent restraints, every 24 hours. The RN must assess every 1 to 2 hours. That means removing the restraint, checking for pulse, checking for numbness, doing capillary refill. Those are all things looking for the skin integrity. Okay, and we must follow the policy. So violent restraint, so this is a patient that is, maybe demonstrating aggressive behavior. They could be confused, and the patient must be assessed every 15 minutes and documented. This is the kind of patient that's going to have a sitter at the bedside, and this violent restraint expires in 4 hours. And of course, we must follow the policies. Okay. All right. Any questions about the restraints? Okay, so that's a good
I have
one.
one, Dean.
Yes, Shaitavia.
Would the doctor ever give you an intermittent time of when the restraints can be removed, or would they constantly just be on for the time that they allotted?
Okay, so no, if there's an order for a restraint, the restraint has to be on. The only time you would be removing this restraint is when you're doing your check. But as soon as you finish your check, you put it back on. Now, if the patient is no longer confused, or no longer pulling out their Foley catheter, they're no longer punching nurses, or whatever their behavior is, then we have to notify the provider, and then they will put in, if they feel it's correct thing to do, they will put in a discontinuation for that restraint. So we just can't stop the restraint because you're like, oh yeah, the patient is good now. He's no longer doing, or she no longer is doing X, Y, or Z. Because what happens if, they go back to doing that behavior and they fall or they hurt someone? Now you're going to be held liable for negligence because you did not follow the doctor's order. Okay.
Thank you.
You're welcome. That's a great question, though. Okay, because sometimes you may be asking the question because sometimes it takes a while for the doctor to get back to you or something like that. If that's the case, right, well, maybe they have another doctor that's on call, but you still have to go with the doctor's order. Okay, all right, so that's restraints. That's a big topic. So oxygenation is another topic. Let me ask you all, what do you know about oxygenation? I'm going to stop sharing.
There's different levels depending on the patient's need. And I think in the room, it needs to be, I want to say, about at 95 room oxygen.
Okay, so yeah, so the patient may have different need based on what's going on. So that's true. And oh, you're saying 95. Okay, the pulse ox. Okay, I didn't understand. Now I understand. So yes, you're right. The pulse ox 95 to 100, right? And so of course in a perfect world, we want our patients to have 100%, but that may not be the case. Like Brittany said in the chat that, okay, COPD, we have to watch for excessive use of oxygen. So the max is going to be 2 liters, right? 2 liters of oxygen via nasal cannula for our COPD patients. And COPD is chronic obstructive pulmonary disease. And I was doing some research because yesterday we were doing the HESI boot camp, and one of the notes she said COPD included asthma, and that's not true. So, and I looked, and I went to, I think, NIH, the National Institutes of Health, or a different one, and COPD is chronic bronchitis and emphysema, but asthma is different, although it is a chronic disease. So, and I'm just mentioning that because Monica was there yesterday, and I was like, I don't know if I like that statement. So, but that's a follow-up. But
I still searched it too. When I go home, I went through it and it wasn't. But they said because most of them display almost similar. Maybe that's why she added it to it.
yes, I'm
They
gonna go.
almost have like similar symptoms. Maybe that's why she added it to it, but it's not. They say it's very different from both of them.
Yes,
Okay.
because that really bothered me. So that's really interesting. Okay, so you looked it up too, because I was like, and I'm gonna go back and look at it again, but asthma is not COPD. So maybe I read it wrong, but yes, but I'm happy that you did that as well. But so yes, anyway, that's a kind of a sidebar from yesterday. But what do you all need to know? What Brittany put is right. We don't want our COPD patient to have excessive high levels of oxygen. It's usually just 2 liters via nasal cannula. Now, your COPD patient, when it comes to oxygenation, they're not going to probably have a 100% pulse ox. The COPD patient that's chronic bronchitis and emphysema, they'll probably live at 92 or 93% on their pulse ox. Okay, and that's going to be good for them. Okay, that's going to be good for them. Okay, so we think about oxygenation. Another concept to understand is if the patient is having a continuous oxygen, we want the oxygen to be humidified because that will help keep the mucous membranes moist, because we know that oxygen can dry out the mucous membranes. If the mucous membranes dry out, start cracking, boom, then now we have a place that infection can set in. Okay, never use any nasal cannula, mask, or anything that falls on the floor and then put it back into your patient. Because what you're doing is introducing whatever's on the floor, the MRSA, the Streptococcus, the C. diff, whatever's on the floor. Now you're putting it into their respiratory system. Okay, so that's an important concept. Okay, sleep. Let's talk about sleep hygiene. What can you all tell me about sleep?
I believe adults are supposed to get 6 to 8 hours of adequate sleep.
Okay, yes. Okay, yes, okay, very good. So that's true. Sleep requirements change as we get older. Okay, so as we are infants, newborns, they're sleeping 16 to 20 hours of the day, and then it decreases as we get older. So your geriatric patient will need less sleep than a young adult patient. So that is true, Shaitavia. Something that Brittany is putting in the chat. Check if your patient has a nasal cannula. Check around the nose, check around the ears for skin breakdown. And that's a great point, right? This is a fundamental thing. If your patient has any device, any tubing, anything that is connected to them resting on their skin, be it an NG tube, nasal cannula, Foley catheter, chest tube, anything, we always want to check to see if it's placing pressure on the skin, because they can get a pressure ulcer. And yes, they could get a pressure ulcer from an NG tube pressing on their skin. Diabetic patients on volume should be wakened for meds. Okay, so yes, diabetic patients should be awakened for when it's mealtime, right? We don't ever want our patients to really miss a meal, especially our diabetic patients. Okay, that's going to be really important. Okay, so yes, great things. So when we think about, and so that's great because we're thinking about sleep. We usually don't let our patients take naps. The only patient that I'm like, okay, it's okay for them to take nap would be your mental health patient, your bipolar patient, because your bipolar patient can go for days without sleeping, and we are concerned about cardiovascular collapse. We're concerned about them, and they're not resting because they're up, they're moving, and the heart is not designed to do that. So that's a cause for concern. So that's a patient that I would let sleep or take naps during the day. But taking naps during the day is not really a good idea because it actually will disturb their sleep pattern or their circadian cycle, right? The other thing with sleep, exercise before sleep is not a good idea, because when a patient exercises, they increase their heart rate, they release these endorphins that kind of get them pumped up. So we want them to refrain from exercising at least 3 hours before the time for them to go to sleep. Think about sleep hygiene, right? And so low light, low stimuli, stay away from screens, our cell phones, right? All of those things go along with sleep hygiene. If the patient has sleep apnea, they must wear their CPAP, because that continuous pressure of air that's delivered by the CPAP is reminding the patient to breathe. Because we know with obstructive sleep apnea, the patient has a blockage, maybe they're overweight, they have a wide neck, or they have maybe large large tonsils, large tongue, large adenoids. There's something that's blocking their airway. So they're snoring and they're not getting enough oxygen. So that CPAP will help them, because the problem with patients that have sleep apnea is that they're not getting enough oxygen and they're at risk now for stroke and heart attack. Okay, so it's pretty significant. Okay, skin integrity and wound care. I feel like that is a good thing. We kind of talked about the wounds a little bit, the pressure ulcers. Just remember friction, shearing. The geriatric or elderly patient has a loss of subcutaneous layer, a loss of collagen and elastin, making their skin very fragile and more prone to tears. And so the other thing with your elderly patient, right, we always want to think about considerations for our elderly patients, is that they don't have to take baths every day, because, and their skin is very fragile. So we don't want them to take baths every day to dry out their skin. And we also want them to use a moisturizing lotion. So those are great considerations when you're talking about your geriatric patient. All right, safe medication administration. That's something that is also talked about in foundations. When we think about safe medication administration, what comes to mind for you all?
Right route, right patient, right medication, right to refuse, the rights.
Mm-hmm. The right documentation, the right patient teaching, the right effect. Yes, all of those. Very good, Nikaya. So we want to make sure we check our medications 3 times when we pull it from, the Pyxis, or whenever we get it from the medication cart, whenever we're preparing it. And then right before we give it, we're going to check. So those are the 3 times. We always assess for allergies. And if we don't know the reason why we're giving a medication, we need to look it up, because as we're giving the medication, we have to do some patient teaching. Sometimes we may have to get vital signs, or we may have to get a blood sugar before giving a medication. So great job, Brittany. Watch out for medications that look alike. Right, so we just finished a couple hours of pharmacology, right? We think about medications that look alike, nurses, medications that need 2 nurses to check, like your insulin, like your heparin, like your blood, right? Those are all, things that need 2 nurses to check. If the patient is on like a cardizem drip or a heparin drip, an insulin drip, that means it's given IV. That means 2 nurses must check, right? And always think about, why am I giving this medication? What is my initial nursing assessment that I must make before giving this medication? And are there any parameters in which I would hold the medication? Like digoxin, for example, I would hold it if the patient has an apical heart rate of less than 60, right? So, and then once I give the medication, I have to look out for the side effects and adverse side effects. Side effects being, okay, something that may happen, the patient may have a headache, they may have dizziness. Adverse side effect could be anaphylaxis, okay? The patient may lose consciousness. So understanding that. Those are all going with safe medication administration, checking the armband, making sure it's the correct patient. All of those things go with the rights. Okay. Fluid and electrolyte acid-base balance. Okay, so that's an important concept. All right, and I'm going to try to save at least 15 minutes for questions, but let me bring this up because this is important. And I just want to do some questions with you, just so we can practice breaking down the questions and kind of thinking them through. Okay, let me share my screen because I want to talk about these. Now, when you get to Med Surg, you're going to get into these in detail. But for foundations, we're just going to look at the differences between these two and maybe what kind of patients you would expect to see, right? And this is under our fluid electrolyte, acid-base balance kind of section, okay? All right, so when we think about these acid-base balances, we think acidosis and alkalosis. We know that the human body lives at a pH of 7.35 to 7.45. And so when we think about, let me think if I need to get into that level of detail. I'll just go ahead and mention it anyway. So the pH is 7.35 to 7.45. Our PaCO2 22 to, is that right? 22 to 26 and 35. No, that's not right. That's 35 to 45. And the bicarb is, okay, hold on, let me erase that because it might be confusing. Okay, let me see. Okay. Okay, all right. Now my bicarb HCO3 is 22 to 26. Okay, so 3 different values that we're looking at. And I'm not going to go far into the tic-tac-toe part of it, but I'm just giving you these values just in case you do see it. I don't know if you will or not, but what's more important for you to know at this level is when we think about respiratory acidosis or respiratory alkalosis, okay, we're looking at the PaCO2. Okay, PaCO2 meaning the partial pressure of carbon dioxide. So if the patient has increased levels of carbon dioxide, they're going to have respiratory acidosis. So that means their carbon dioxide is over 45. Who would be this kind of patient that would have respiratory acidosis? Well, my COPD patient, because they can't exhale all of their carbon dioxide. My patient that maybe has received anesthesia. My patient that has pneumonia. My patient that has atelectasis or the lungs collapse. That could be a patient that has respiratory acidosis. Okay, how will this patient look? Well, you'll see on the left, it says they have rapid, shallow respirations, dyspnea, headache. They have dysrhythmia because of increased potassium. Okay. Now, respiratory alkalosis is the opposite. Respiratory lungs, alkalosis, they're basic. This is a patient that is releasing too much carbon dioxide. This is a patient that may be having an anxiety attack. Maybe they're having panic. They're fearful. Maybe this patient is on a ventilator, right? This is a respiratory alkalosis patient, okay? I'm going to pause for a second because this is a kind of important concept to grasp. Any questions?
Yes, could you say it just one more time? Because it seemed like I understand it, but then when I get on the exams and stuff, I've mixed it up for some reason.
Okay, so sure. So these are the values that you should know. The pH is 7.35, 7 to 7.45. Your PaCO2 is the partial pressure of carbon dioxide. And those values, I don't necessarily think you need to maybe know them at this time, but I'll just mention them just in case, 35 to 45. Your bicarb is your HCO3. That is going to be, normal level is 22 to 26. When I think bicarb, I think kidneys, okay? So what kind of patients, when we talk about respiratory, will have respiratory acidosis, meaning that they will have high levels of PaCO2. They can't get rid of their carbon dioxide well. This is a patient that has COPD, a patient that has pneumonia, that has atelectasis, which is a collapse of the lung. And so this patient will have hypoxia, meaning that they don't have enough oxygen. They'll have shallow respirations, decreased blood pressure. They can have difficulty breathing, headache, high levels of potassium. That's your hyperkalemia. They can have dysrhythmias. Now for respiratory alkalosis, they're getting rid of too much carbon dioxide. And so they will have possibly hyperventilation. If you ever seen on the movies, like if somebody's in a panic attack and like, hey, take this brown paper bag and breathe into it, right? Because what they're doing is they're inhaling their own carbon dioxide. So that's what they're trying to do. So alkalosis, they're getting rid of too much carbon dioxide. Remember, the carbon dioxide is acidic. So when we think about this, a patient that could have respiratory alkalosis, they could be hyperventilating because of a panic attack or high levels of anxiety or fear, or maybe they're on a ventilator, okay? The other thing that goes with it, if you see the other signs and symptoms, they can have seizures, rapid breathing, tachycardia, hypokalemia, right, which is the opposite of what we just saw, numbness and tingling of the extremities. So all of these things on the left are what you'll hear your instructors call clinical cues. How will the patient manifest? What will they look like? What will they complain of? Or what will we see? And that's what Next Generation NCLEX is all about, the clinical cues. As you're caring for your patient, when they tell you, I have hyperventilation, the lab work shows hypokalemia. They tell you I have numbness and tingling in my fingertips. So you should know, whoa, this is possibly respiratory alkalosis. Okay. All right, I'm going to pause here and see if Brittany has any questions.
I don't.
Okay, hopefully that helped. Okay, all right. Now, the other part of this is metabolic. When I think metabolic, I think bicarb, okay? I think bicarb, bicarbonate. So I think kidneys. So metabolic acidosis, this patient could be in DKA, diabetic ketoacidosis. Well, that makes sense because acidosis is part of the name. This patient that has severe diarrhea, renal failure, or shock can have metabolic acidosis. Okay. Now, Kussmaul respirations, this is a compensatory kind of hyperventilation. It's kind of a shallow, rapid kind of breathing. The patient may also have changes in their level of consciousness. And, they may have muscle twitching, decreased blood pressure, hyperkalemia, flush, warm skin, nausea, vomiting, diarrhea. So again, these manifestations, signs, symptoms, clinical cues, what does the patient look like? Paint a picture in your mind of what this patient looks like. That is metabolic acidosis. Something's going on with the kidneys. Okay, now let's look at the opposite of that, metabolic alkalosis. The patient has confusion, decrease in their level of consciousness. They're dizzy, irritable, nausea, vomiting, tremors. Okay, so when I think about metabolic alkalosis, I think of a patient that is NG tube to suction, meaning that, okay, they were taking away all of their stomach acid. So guess what? They're now alkalotic because we have removed all of their stomach acid. Okay. So we have to really be careful when we have this kind of patient. So a patient that has severe vomiting, okay, a patient that has severe vomiting, they can have metabolic alkalosis. If we have excessive GI functioning, that's in the case of your NG2 patient, your patient that's on diuretics, or again, if the patient has excessive bicarb, sodium bicarbonate. Okay, that is your metabolic alkalosis. Metabolic, always think kidneys. Respiratory, always think lungs. If it's acidic, in the respiratory, they've got too much carbon dioxide. If it's acidic for your metabolism, I want you to think the patient that is a DKA patient, okay? A kidney patient, a patient that's in shock. If it's alkalotic, I want you to think of a patient that, hey, they're losing stomach acid. It could be due to vomiting. It could be due to GI suction. Okay, so that can kind of help. Any questions on that?
No.
Okay, great. All right, going to continue. Okay, so injections is something hopefully you did in your skills lab where you were preparing injections and the injection sites. Let me put in the chat actually. I'm going to stop sharing for a second. I have kind of a cheat sheet with for injections with the sites and the sizes. Let me see, funds. Maybe it's under, oh, this is actually an important one, therapeutic diets. Let me send you that one right now. Okay, so you should have that therapeutic diet once. If you're in my class, you might already have that one, but not everybody here is in my class. Okay, what's the other one I was looking for? Let me see. It's the farm. Okay, it's the injection site cheat sheet. Okay, so let me send that one to you. And I'm just going to share it just for the sake of those that may be watching on video. Okay, so the injection site cheat sheet is here. It tells you, you know, the different kinds of injections. So we have intradermal, subcutaneous, intramuscular. It gives you the location. That's an important thing. The needle length and the needle gauge, and then the angle of insertion. So those are all kind of important things to know. Remember the intradermal injection is 5 to 15 degrees of angle. It's a very small angle. Subcutaneous, the angle of insertion of the needle is 45 to 90 degrees. And for the intramuscular injection, we're looking at 90 degrees. I think your textbook does say 5 to 15. My sheet says 10 to 15, but make sure you're going with what your textbook says. If there's a difference between that number and what you see, go with your textbook. Okay. So here we have on this sheet, we have subcutaneous injection sites. So when we think about subcutaneous, we are going into that subcutaneous layer that's under the dermis. An example would be like your insulin or your heparin. Just remember, heparin is 2 inches away from the umbilicus or the belly button. Intradermal, think about your PPD. Right, that's your test for, you know, tuberculosis or the MAN2 test. And those are the different sites. We think about intramuscular sites, especially for your children, your pediatric patient, we're going to be using the vastus lateralis. Remember the landmarks. We're going to go from the hip to the knee, divided into thirds, and we're going to go for the middle third. That's where we want our injection to be on the vastus lateralis. The deltoid muscle is also a place where we can give intramuscular or IM injections, and also the ventro-gluteal site, dorsoventral-gluteal site is a site here. Remember the landmarks. We're looking at the hip, and then you make a V with your fingers, and you're going to go right in between your fingers. So that is your injection site cheat sheet. The other thing is I just gave you all that nutrition handout in the chat. That's going to be important when we think about nutrition. We think about the different kinds of diet. Think about mechanical soft, liquid diet. Those are all important things for you to know. Let's see. Urinary elimination and bowel elimination. I know we talked about that a lot in class, but not everybody here is in class. So let's just mention a few things like the Bristol stool chart. Okay, I promised my daughter that we're going to be making a Bristol stool cake. So hopefully we can do it this week. I don't know. We'll see. But that's one of our things to do this summer. And so we think about the Bristol stool chart. That is how we kind of grade or rate our stool for the patients. 4 is the goal. Anything above 4, we're thinking the patient's dehydrated, they need more fluids. Excuse me, they're approaching constipation. 5, 6, and 7 is getting more watery, headed towards diarrhea. Of course, we're concerned about the patient becoming dehydrated. Okay, if the patient has C. diff, then type 7 is what you would probably see. Okay, so when we think about urinary elimination, every adult should have 30 mLs per hour. Unless they're a dialysis patient, we look at the color, the consistency, the character, the amount. We know that if it's cloudy, it may be indicative of infection. If it has a bad odor, malodoriferous, that could be indicative of infection as well. So those are all important things to think about with urine and urinary output. For women's health, we think about cotton underwear, wiping from front to back, voiding before and after intercourse, cranberry supplements. Those are all important things when we think about the health of our urinary system and urinary tract. For males, I think about BPH, benign prostatic hypertrophy or hyperplasia. The prostate could be enlarged, and that patient will have frequency, urgency, hesitancy, a feeling of incomplete bladder emptying. Those are all, important things. If your patient has issues with their bowels, I am going to recommend pushing fluids, activity, and fiber, right? Those are all things that go to help our patient, that has issues with their bowels. The other thing is if the patient is trying to use a bedpan, give them privacy, maybe elevate the head of their bed. And put the call bell right there. So if they need you, they can call you. Okay, enemas go along with bowel elimination as well. If you see a question and it says you're delivering it or administering an enema and the patient reports cramping, lower the bag because we're inserting the fluid too quickly. So we want to lower that bag. Okay. Okay, death and grief and dying. So we think about DABDA. I'm going to stop sharing for a second because I do want to go over some questions. DABDA, death. Okay, DABDA. We think about the stages of grief and loss by Dr. Elizabeth Kubler-Ross. We're thinking about denial, anger, bargaining, depression, and then acceptance. Those are the stages, and your patient may be going through grief and loss, or the family may be going through grief and loss. There could be anticipatory grief. If the patient knows that they have to have a mastectomy, they're going to lose their breast, or maybe an amputation. Those are all things that can go along with it. Okay. All right, I'm going to stop there because there's a lot of concepts that we've talked about, but I want to show you, some of you may already know this, but I'm going to start with this HESI, Green HESI book, and we're going to go to student practice questions. So before your HESI, you should have exhausted all of these questions, and you may say, well, these questions are too easy. Okay, or maybe they're too hard, but the bottom line is these concepts are concepts that you're going to see again and again. Okay, and so I'm sharing my screen. You should see the Green HESI book. For LPNs, you should use the Burgundy book. So using this book and your Saunders book is really a good idea. So for example, we're talking about fundamentals today. So click fundamentals. I'm going to begin my study session. And so I'm going to give you all a chance to look at this question and put your answers in the chat, please. Okay, I see your answer, Shatavia. Thank you. I'm just going to give one more minute in case others are still reading the question. And this is a tricky one because it's select all that apply. Okay, I see your answers, so Monica, thank you. Okay, so let's talk about this question, and if you still want to put your answer in, that's totally fine. So breaking down this question, the client reports to the clinic nurse, I sleep for about 2 hours and then I have to get up to use the bathroom. So I'm asking, okay, what is this question asking me? This could be a urinary kind of question, or it could be a sleep question. I repeat that pattern about 3 to 4 times a night. So this tells me, number one, this patient's not getting adequate rest. This patient may have issues why they have to get up and keep going to the bathroom. It could be maybe their medications. It could be that they have high blood pressure. There's many different things could be going on with this patient. So what questions will the nurse include in this client's assessment? So this will select all that apply. How much fluid do you drink after 8 in the evening? Okay, so I see we'll go with what Amanigo has checked, because I'm going to show you how you can use this to kind of test your knowledge. So does your spouse wake up with you to use the bathroom after you? So does that have anything to do with the patient, right? So what time of day do you take your water pill, right? And so water pill is a diuretic, and that's going to make them diuresis, okay? And so I'm going to check that one because Omanigo said to. All right, do you drink any alcoholic beverages in the evening? She said yes, okay, to check that one. And so that kind of makes sense because we know that alcohol is a diuretic. Okay, when did this pattern of urination start? And that's a good question, I think, because we have to figure out, okay, how long has this been going on? What has changed? Okay, do you have any itching or burning when you urinate? So if the patient has itching or burning when they urinate, that's dysuria. That could indicate a urinary tract infection. So and again, I just want to put a plug in. If you have not exhausted all 125 of these questions for your fundamentals, please do so. And you may say, well, these questions are not exactly like the ones on the HESI. Well, the topics are going to be the same because guess what? There's only but so many topics. If you have 125 different opportunities to see different topics. So this is going to be a great opportunity for you to study this way. Okay, so boom. Oh, so I went with what Amanigo said and she got all of them correct. Okay, the big thing is the spouse has nothing to do with this, right? And so let me ask Omonigo to give us a little bit more clarity if there's anything that I'm missing that you want to add.
So far, I didn't really see anything there that I need to add, because when I read the question is I was like, because I know if I drink water after 8, I use the bathroom a lot at night, which is one of the things I took into consideration. And on another thought, it said it repeated it 3 to 4 times in the night, which means is he on water pill that he doesn't realize? And I know people that drinks, they normally use the bathroom, and if there is change in his pattern of urinating, maybe then he need to like cut down his drinking before he goes to bed. Then on the last thought, I was like, okay, does he have any UTI? Is there any burning sensation? Because we have to come in clinically now to see if he's safe or he has to go see the doctor. I mean, he has to report to the nurse what he's going through so that they can start treating him or do tests on UTI for him.
Okay. All right. Well said. Okay. Excellent. Okay. Great. Let's go to the next one. Okay. So break this one down and put your answers in the chat. I'm going to give you some time. And I do have one of my students from the next class. That's okay. You can answer too and see what you know. Okay, McKay, I see your answer choice, so thank you. Okay, Shatavia, I see your answer choice as well. Thank you. Okay, awesome. So I see a lot of B's there. So a nurse is working in an occupational health clinic when an employee walks in and states, I was walking outside and I believe I was just struck by lightning. The client is alert, but reports feeling faint. Which assessment will the nurse perform first? This is a priority question, right? And so we're like, whoa, this is, okay. Okay, I feel like, okay, so I see B and I see A. Okay, so I'm gonna go with B because the majority of you said that, okay? So the client is alert but reports feeling faint. Okay, so you all are stuck between A and B, and that's okay. So which assessment will the nurse perform first? So this is a priority question. Now, something that I mentioned, I hope I didn't mention, is that we're in study mode, right? So if you feel that, okay, you are ready and you're like, okay, I'm going to take my, my HESI and I'm ready. I feel like I studied, I know it. Go ahead and take it in exam mode. And you can take it as if it's the actual exam. But if you're like, I want to study, I want to take notes, the things that I don't know, I'm going to look up and I'm going to really take my time, because you don't have to do all the questions at the same time. For the LPNs, I think it allows you to take 10, 15, 25, 30 questions at a time. Okay. And so McKay is saying she's thinking ABCs. Well, let's see what they say. The correct answer is A, okay? So Omonigo was correct, okay? So this is a kind of a tricky kind of question. And I know that we always say ABCs, ABCs, right? But guess what? If the patient is talking to you their airway is clear, okay? They are breathing if they're talking to you. But let me go to Amanigo and let me ask her what was her thinking before we go to the rationale.
That was what you just said. I was like, if it's talking, which means it's okay, because if the airway is not clear, which means it's definitely shaking and there's something wrong. For the client, for the staff to walk back and start talking, which means everything was fine. So it's just to check the pulse rate. Let's see how the pulse is, and let's see if it is up or down so they can be controlled.
Yes, and so you're right. The thing with electrical shock, and if a patient gets shocked by lightning, or if they stick their, finger in an electric socket by accident, or the thing is, the heart operates with electrical impulses. So that's why electrical shock is so potentially dangerous, okay? And so this is kind of a random question, like the patient just comes in and said, "Hey, I think I was struck by lightning." This kind of question is kind of weird. Like, it's unusual, but it's really testing you. Do you know about electrical shock? Okay. And so if this patient gets shocked in whatever way, it can change the heart's rhythm. Okay. And that's what they're testing. Okay. And so the patient is talking, he has an open airway. Okay. So that was kind of tricky because we always say ABCs, but if somebody's talking, they're breathing. Okay. All right. Any questions about that one? Okay, we're going to do one more because I know my other class is coming on. So we're going to do one more. And please, if you have not done these questions, I'm going to go to the LPN side just to make sure everybody can see it. Because that's important. Okay, so go to my products and we'll do one for the LPNs. Okay, but if you haven't done this, please exhaust all 125 questions because the concepts are what you're really looking to understand. Okay, so I'm on the LPN side and I'm going to go into study mode, and I'm going to do 10 questions. We're not going to do 10 questions, but we're just going to show you how it works. Okay. So the practical nurse obtains lying and standing blood pressure measurements for a patient who complains of dizziness. Wait a minute. This is like, I think, the question that you were asking before. The PN determines that systolic pressure decreases 24 meters of mercury when standing. What intervention is most important for the PN to implement? Recommend that the client drink plenty of water every day. Determine if the client takes antihypertensive medications. Encourage the client to flex both feet before rising slowly. Review the client's history for any incidents of syncope. Okay, take some time to answer this question and then we're going to break it down. And it's actually funny that we see this question because this was a question that we had at the beginning of the session, I think. It's not exactly the same, but the concept is the same. Okay, so let's look at this. So what is this? What is going on in this question? What do you think? Boom, Brittany, you got it. Okay, okay, good. So the question is not exactly the same as the one that you shared, but the concept is still the same, right? And so I see, I'm going to go with what Brittany said. What did Brittany say the answer was? She said it was B. Okay, so we're going to click. Okay, so that's not correct. Okay, and that's okay. Now, what I saw another answer and she said C. Okay, so we're going to click. Okay, boom. Now we're going to show the answer. Okay, and that's the rationale. That's what they mean when you see this. Okay, so you were right when you said orthostatic hypotension. Okay, so that's going to be important. So we know because of that last question, remember that venous issue that the patient had that caused the drop in blood pressure, right? So if the patient is drinking plenty of water, that has nothing to do with it. If the patient takes antihypertensive medication, that's not a bad question to ask, but it's asking you what intervention is most important. So what is the priority? Okay, encourage the client to flex both feet because if they flex their feet, that will help them to get the circulation going, right? That's what we're talking about. That's going to promote blood flow back to the heart. Okay, and review the client's history for any episodes of syncope. That's a good thing to do, but that's not the priority. Okay, let me go to Amanigo, and I should have went to you first before I was blabbing. What do you think? How did you get the right answer? Oh wait, Brittany.
I've worked with such a patient before now.
Ah, okay. So you work with that kind of patient before. So
Yeah.
another thing that they could do then, if because Omanigo said that's what she did with her patient, is before the patient gets up, if they're in the bed, they can dangle their feet, right? They can dangle their feet and they rise slowly. But again, this is an orthostatic hypotension. Okay, and I did not see it said hypertension, it's hypotension. So low blood pressure, okay, hypotension, okay. Orthostatic meaning changing positions, okay. Hypotension meaning low blood pressure. Okay, Brittany, I see that you're back in. Did you have any questions about this one?
No, so hold on, it says encourage the client to flex both feet before I was looking at that but I got confused because I was thinking about orthostatic hypertension where the person has to lay down, sit up and stand up, but I don't know. I got confused about flexing the feet.
Yes, so flexing the feet will actually promote the blood flow. So have you ever had, this happens to my daughter all the time. She's like, oh, mom, my foot fell asleep, or if she's sitting in her car seat and she's crossing her legs, I'm like, it's okay. Just extend your legs and then point your toes, flex your feet, point and flex, because that's going to promote the blood flow to
Okay.
go back to the heart. Okay.
Okay.
So I think you have a little bit better understanding of orthostatic hypotension, but just remember that it's blood pressure that the patient is going low because of this issue with their venous circulation. So what do we do to promote venous circulation or blood flow back to the heart? We either elevate their extremity, we have them move around, and in the case that we're afraid that they may be dizzy and fall, we have them dangle they just sit there and dangle their legs for a while until they no longer feel dizzy, right? So those are the different things that can be done for a patient in this condition. But just remember, it's orthostatic hypotension. And if you had to take this patient's blood pressure, and you're right when you say lying, sitting, standing, if you had to take an orthostatic blood pressure reading, you would take it when the patient's lying down, you would take the blood pressure when they're sitting up, and then you would take their blood pressure when they're standing. So those are all concepts that go with this orthostatic blood pressure scenario. Okay, does that help a little bit? I don't know.
It does.
Okay, awesome. So I No, you're not able to challenge questions on the HESI. Now, if you feel really strongly, like if it's something that's totally crazy, and even if the instructor challenges, we can definitely submit like, something to evolve. We can do that, but that's not a guarantee that you'll get any points back. So I don't want to say you could never challenge. You could challenge it for sure. The problem is the instructors don't see the questions. So I don't really know what exactly the questions are asking you. So you'd have to give me some details on what it was, but instructors don't have access to the HESI. We don't know what the questions are asking you. We just know that, okay, it's coming from foundations, and these are things that you should know in foundations. It's coming from farm, these are things you should know. So if that makes sense. But you can always try. I don't want to tell you no, but it's a process that we could do. Okay, so I see my other classes coming. We've got a couple students. Let's just do one more, and that'll give my other group a chance because not everybody's here. I have like 2 or 3 students from my other class. All right, so take a moment. Doing the bow tie questions. Okay, so that's a great question. Okay, answer this, and I'm going to give you a resource that has a whole bunch of bow tie questions so that you can do them. And that's a great question, Brittany. I'm glad that you're asking it, okay? All right, make sure you put your... Okay, yes, of course, of course. Thank you for being here today.
Thank you.
You're welcome. Take care.
Yes, ma'am. Thank you. Have a good one,
Welcome.
guys.
You too. Thanks.
Your next Zoom, what is that over?
This is for my foundations class. Well, it's the PN's basic skills class.
Okay.
It's the one that I always get confused, that I'm like, did I tell my Wednesday night class or did I tell my Friday night class? Because a lot of the topics are the same. Okay, and I'm going to put this link in the chat because I'm going to share it with everybody also. So I see Brittany saying it would be C. Okay. All right, so let's read this. So the practical nurse determines that a client's radial pulse is irregular. Okay, so remember your radial is by your thumb. Ulna is pinky side, okay? So what action should the PN take first? Record the client's pulse rate and irregular rhythm, review the client's 12-lead EKG and report it in the medical record, take an apical pulse for 1 minute to verify irregularity, and that's what you said, report the finding to the healthcare provider. Okay, so that is correct. And guess what? The apical pulse is going to be the most accurate because you're listening at the base of the heart. Okay, so too much digital pressure can obliterate radial pulsations, especially if the client has a weak pulse. So a different assessment technique is indicated. So guess what? We're using ADPI. Okay, we're using ADPI in this sense. Auscultation of the apical heartbeat for 1 minute is the most accurate method of evaluating cardiac rhythm and verifying the irregularity. Okay, so good job. Okay, so you got that one. Anybody have any questions about this question? All right, I'm going to show you all. I put the link in the chat. This is a cool website. It's on the internet. It's free to anybody. So this has the bow tie questions that Brittany was asking about. So you're going to go under faculty case studies, and you are in fundamentals right now. So I would probably stick with this. Okay, so home safety is one that you could probably see, right? Actually, pressure injury was a better one, but you can go to anyone that you feel like going to, right? This is open to the public. You're not breaking any laws or anything by by doing this. So let's do the pressure injury. So they have the case studies. And so if you click on the faculty part, you're going to get the answers in a Word document. Okay, so if you want to, before you look at the answers, if you want to test yourself, when this document comes up, you will click bow tie. Okay, and it will give you a bow tie question. And some of you may not know what a bow tie question is, but here's an example of one. It's a 19-year-old, right? So you'll read the notes and everything, you'll get all the information, and then you'll answer the questions. Now with the bow tie, it's usually one thing in the middle and then two parameters on either side. So based on this condition, I don't know, I didn't read it. He has paraplegia. Let me see. Okay, I'm gonna just guess, looking at it quickly. So I'm thinking that he has this kind of condition, and what am I going to do? What would they do? We're gonna address the condition, and I probably shouldn't do this one because you might do it. So I'm not gonna do the answer because you can look it up. And two things to monitor, okay? Now, this is not going to give you the answer. You're going to have to go back to that original Word document that I showed you that had the link to get the answer, okay? But I'm not going to show you the answer because you might want to do it because this is actually a good one. Okay, so I'm going to go to Brittany because she was the one that asked the question. Number one, do you have the link? And number two, do you understand how to use it?
Yes.
Okay, perfect. Okay, so for those of you who are just coming back in, I put the link in the chat for some NGN case studies and specifically the bow tie. But you can use it. The answers are under faculty case studies. And this is a free thing on the internet that I found one day. You're not breaking any laws by looking at this, okay? I do use this sometimes when I do my NGN sessions, but again, you know, it's free on the internet. So I think it's a great resource. Okay, I'm going to stop sharing. I'm going to stop recording.